at this point, I'm looking at the CAT scan, I'm like, wow, this is crazy. If I didn't get that cervical angiogram, that CT angio, this patient would have probably died in the operating room, which would have been crazy my first few months out in practice. So what has been my craziest case of 2021? Well, in this video today, I'm gonna tell you guys about that case, how I managed that particular case, and what I learned from it. What's up, everyone? This is Dr. Antonio Webb. I'm an orthopedic spine surgeon here in San Antonio, Texas. In this video, basically, I'm gonna be telling you guys about the craziest case I've had in 2021. It's been a very busy year. It's been a crazy year with lots of ups and downs. Everything going on with the COVID-19 and hospitalizations and surgeries kind of being on pause, elective surgeries, and a lot of crazy stuff has happened in terms of my practice. My practice is certainly growing on a good trajectory, and for most surgeons or new doctors, it takes 3 to 5 years to build a fully functional practice. But I've learned a lot this last year, and my most craziest case, the most interesting case I have seen, we're going to talk about that. So let's jump right into it. All right. So the patient was a 67-year-old patient who presented to my office. This patient had high blood pressure as a past medical history, but presented to my office with neck pain. This neck pain had been going on for a few months. This patient had fallen several months prior to seeing me. She had some pain in her neck and some in her chin from when she fell. But then her pain didn't essentially get better, so she decided to come in and get seen. She didn't have any weakness in her arms or leg, but she did have some numbness and tingling in all of her fingers. And whenever a patient has numbness and tingling in their fingers, could be a lot of different things. It could be something systemic like vitamin B12 deficiency, which is not that very common. The more common things being something in your neck, like a cervical disorder that is causing compression of the nerves that can cause numbness and tingling. Or it could be like carpal tunnel syndrome, which is compression of the median nerve in the hand. It could be cubital tunnel syndrome, which is compression of the ulnar nerve right here at the elbow. But this patient just reported this tingling, and it was pretty bothersome for her. This is her physical exam right here. You can see that she had full strength in her extremities. So when a patient comes in, especially to a spine surgeon, we're always checking their strength and see how strong their muscle groups are in the upper part of their body and the lower part of their body. If a patient, let's say, has weakness, when I'm telling them to push off in terms of this motion here, that's their triceps, I kind of have a general idea that there may be some pathology at the C6, C7 level, because that's the level that is responsible for that nerve coming out and innervating the triceps muscle. So I look for that on my imaging studies to see if there's not like a large disc herniation there or some type of tumor, bone spur that could be causing some weakness of that triceps. The rest of her physical exam was pretty benign. These are the x-rays here. So the lateral view is this one right here. You can see this is the front of the spine, this is the back of the spine, the head is up here, the chest is down here, and this is what's called the AP view, from anterior to posterior, the way they shot the x-ray. So we always get a minimum of 2 views, sometimes 4 views to assess the spine. And you can see right away, there's something unusual right here at the cervical vertebrae. So this is the second cervical vertebrae, third, fourth, fifth, sixth, seventh. You can see there's either some type of fracture there or something that's causing the bone to essentially crush. Not sure exactly what it is, but it is essentially there. You can see it partially on the AP view as well. These are what's called flexion extension views. So we get these x-rays to see if there's any instability or movement of the spine. And sometimes the vertebrae will shift forward. You can see that on the flexion extension view. That's considered an unstable segment of that spine. So what could this be? So differential, things that you have to think of when a patient comes in with a particular presenting symptoms or symptomatology? What do you think the diagnosis is? So you run through this list in your head and you exclude things based off the history, the physical, the imaging studies. So it could be an infection, it could be some type of tumor or cancer, tuberculosis, very low likelihood of that, but you do have to, you can put that in your differential. This could be from trauma. Did she actually fracture these parts of her spine when she fell? It could be any of these things. So, but this is essentially a quick list of differential things that could possibly cause her symptoms. This is her CT scan. So I actually sent her for a CAT scan just because I thought that area looked a little bit unusual. When a patient has a fracture in any part of their spine, you have to make sure it adds up with the history. So if she fell, maybe hit her chin, could that cause 3 or 4 levels in your spine to break? Not really, but it is possible, especially if a patient has weakened bone or if there's osteoporosis, some type of tumor or infection that causes that bone to be very weak, then that bone certainly could fracture or break just from a fall from standing. So I got a CT scan because I was a little bit concerned about it and showed these lesions here in the spine. These are what we describe as lytic lesions. Something inside the bone is destroying the bone, causing it to fracture like this. You can see all of this bone right here is missing. This one's here is really collapsed down. You can see all these little spots in the bone. So at this point, I'm looking at the CAT scan. I'm like, wow, this is crazy. What is this? I first thought that possibly it was some type of cancer. And I asked her, hey, do you have any history of cancer? Do you have any fevers, chills, weight loss, any of those things, night sweats, loss of appetite, any other constitutional symptoms is what we call it. And she didn't have any. This is another view of the CT scan here, and I'm scrolling down the CT scan. You can see all of this bone right here is kind of destroyed. This is the where the vertebral artery kind of runs, and you'll see that whatever this is, it's involving this artery right here. So that's not good. And you can see that this has expanded. So that little circle for the vertebral artery has expanded on both sides. You can see it's even large here. So at this point, I'm like, man, this is crazy. This is pretty interesting. I've never seen anything like this before, especially in the cervical spine, but we need to look into this even more and get some further diagnostic workup and imaging studies. So I admitted her to the hospital to expedite this and get all of this done. And you can see here some more images of that cervical spine, the CT scan here. Got an MRI scan, and basically it showed some stenosis or tightening of her spinal cord and nerves. And she had some what's called myelomalacia, which is indicative of spinal cord injury. Some areas of increased signal inside of her spinal cord, which can be caused by certain very tight stenosis or an injury or trauma. Just means that there's a lot of water content or inflammation around that area. You can see that here, these signal changes here in the spinal cord. So the brain is up here, the spinal cord is this dark structure going down. This is the front of the spine, this is the back of the spine, this is the front, this is the back here. So after this MRI scan, talked to the patient, I spoke with the radiologist, we reviewed the images together. This is sometimes what we'll commonly do. We'll get together with the radiologist and say, hey, this is the patient's history. This is what I think, it possibly is as a surgeon. And by me looking at the patient and doing a physical exam, and what are your thoughts? So that's exactly what I did. I spoke with the radiologist to review the imaging studies with the radiologist, and kind of came up with a surgical plan, which was to perform a corpectomy. So my plan was to remove all of this bone here, go in the front of her neck, and put a large cage, essentially to stabilize that area. I thought it was pretty unstable, given those multiple levels of broken bone that were right there and the pain that she was having with the stenosis or tightening of the spinal cord. So that's what my plan was, a anterior cervical corpectomy. This is the rest of the workup here. I got some general labs to make sure it wasn't an infection. Her infection labs, the ESR, CRP were negative. The rest of her, we got some labs for multiple myeloma, lymphoma, all those typical labs that you would get when a patient presents with potential cancer, and everything came up negative though. So I'm like, wow, what is this? Could be an infection, but the labs really weren't suggestive of that. Could be some type of tuberculosis. I'm not sure. So I had her on the schedule to do this surgery, and part of my planning process when I was planning to do the corpectomy, I wanted to make sure that the vessels, I needed to know where they are so I can plan how wide I can go with my corpectomy. And I ordered what's called a CT angio. Essentially looks at the vessels in the entire portion of the neck. You can localize them and see where they are. The patient gets contrast, and then the vessels basically light up. Not a typical test that is, or routine test that is ordered, but I'm glad I got that test though, because it showed that this patient had a large AVM, which is a arteriovenous malformation. Very rare in the cervical spine. It showed it was a pretty large one, a type 3. There's a couple different types of them, but you can see it here, all of these vessels that are kind of traversing this area of the spine here. You can see the areas of all this bony and the bleeders, the feeders off of the vertebral artery here going through this area. So AVM is essentially abnormal connection between the arteries and veins. It's usually in the brain or spine. It can rupture, it can cause bleeding into the brain or spinal cord, and these are pretty rare. If I didn't get that cervical angiogram, that CT angio, this patient would have probably died in the operating room, which would have been crazy my first few months out in practice, because she would have most likely bled on the table, which really could have been really bad. So this CT angio essentially changed the course of this patient's management, and the MRI wasn't suggestive of that. The x-rays, nothing before that said AVM. It was just up to me to order that test, and I'm glad that I did, because if I would have opened her cervical spine, all of those vessels would have been there, they would have bled. I'm not sure if I would have been able to stop that bleeding. So a lot of my mentors had never heard of this before, had never seen this in the cervical spine when I checked with them, which is pretty crazy if you think about it. So this is the AVM. You can see the arteries are carrying the oxygen-rich blood to the heart and the brain, and then the veins take that blood away. But when you have an AVM, you have this abnormal connection between the two, and it disrupts normal blood flow. So this was kind of my plan here, was to go posterior. I didn't want to go on the front of the neck just because of that large AVM, the risk of bleeding. I ended up getting endovascular neurosurgery involved, and they embolized the patient, essentially just go in and take away all of that feeder, that blood vessel on the right side of her neck that was feeding that AVM, and they embolized it, which means put some substance into that vessel to cause it to clot, so there's no more blood going through that area. And beforehand, you have to make sure that the patient has collateral circulation into their brain. Otherwise, you'll give a patient a stroke. So you can see here on the video that the vessels in the angiogram, you can see it spinning around here. Basically, they're just checking to make sure that the patient has good blood flow in the other vessel before they tie off and embolize the vessel on the right side. So this is my planning for surgery here, just making sure always before surgery we plan to make sure that we have enough space to put our screws in, and I always measure to see and make sure that the screws will have adequate purchase and bone to go to hold the screws. And these are the levels here. You can see at this level at C5, I wasn't planning to put any screws, just because I thought that this all this blood, this arterial AVM right here, this AVM right here would preclude putting any screws in at this level. And the next level, then at C7 and at T1 here. This is what her construct looks like. So this is after the endovascular neurosurgeon put this embolization and coal into her artery here. And these are the screws and rods that held everything in place, stabilized it. So this is by far one of the craziest cases I've seen over the last year in 2021. Luckily, this patient is doing well. She's about 8 months out from surgery right now, and I'll see her back in her year mark. And this actually, I'm getting written up into a case report and hopefully get it submitted to a journal, just because it's not very common. And I've had a lot of other crazy things happen, and it reminded me to just slow down, talk to the patient, get a really good history, get a really good physical exam, scrutinize your imaging studies, because you get into a habit, into a routine, and you're going from patient to patient to patient. And I've been on call before where I've done like 3 or 4 hip fractures in a row. Bam, 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 bam. And one time I was in a routine. I was knocking out the hip fracture, surgery was going well. When I got to the 4th patient, I looked at her imaging studies and I was like, this doesn't look well. This doesn't look right. And got a CT scan, and sure enough, there was metastatic cancer. And if I would have taken that patient to surgery, I would have spread that cancer like everywhere into her bone. So really slow down. Medical students, pre-med students, study real hard. They don't teach you everything that you need to know. I didn't learn this in medical school, residency, fellowship. I learned this from using my experience, studying, reading, talking to mentors to essentially effectively manage this patient here with a very difficult problem and something that I've never been taught before, but you have to think on your feet. They teach you the basics of the foundation, and it's up to you to be able to use that knowledge to be able to come up with a differential, come up with a diagnosis, and come up with a treatment plan that will be suffice and that will essentially work for that patient. So this is something that I've learned since I've been out in practice, and this is the craziest case I've seen in 2021. I look forward to 2022. Hopefully there's no crazy curveballs or unicorns that come to my office that are like this, but you never know. You gotta be prepared. This is Dr. Webb. Thank you guys for watching this video. We'll see you next time.